Live. Are we live? We are live. Hello, everybody. Hello, and welcome to the fourth presentation of the sixth season of our CF Discovery Series. I'm Siri Vaith, Programs and Outreach Manager at Cystic Fibrosis Research Incorporated, CFRI, and I'm very, very pleased to welcome both our guests who are here in the room, as well as our online guests who are watching from across the country. Hello. We'll get to our very special program focusing on pulmonary rehabilitation in just a moment. But before getting started, I want to thank Genentech and Vertex for generously sponsoring tonight's event, and I thank Activists for its additional support. Thank you. As always, we urge you to work together with your healthcare team, and please note that no information presented tonight is intended for a patient's diagnosis or treatment. We'll leave that to your specialists. Tonight's program is being produced by your CFRI Live team, Scott Wakefield and David Suhu, as well as Mary Convento, who's ready to track questions from our online audience. At the end of the presentation, there'll be a question and answer period, and if you're watching online, please click on the chat box on your screen and type in yours. You may do so at any time, type in the question, and then Mary will hold it until the end of the presentation and ask at that time. I do strongly encourage everyone to ask questions because we have an incredible expert with us here today. So let's get started. Tonight's topic is of vital importance to the CF community. While we know that cystic fibrosis is a systemic disease, pulmonary function is key to one's overall health. Whether working to bring back one's FEV after an exacerbation or learning to breathe with new lungs post-transplant, pulmonary rehabilitation is key. We're very fortunate to have Leslie Rusinak of Camino Hospital in Mountain View, California, with us tonight. Leslie has been a certified respiratory therapist for 37 years, thanks to the advice of a guidance counselor in high school. She decided not to become a journalist. She has a wealth of expertise working with patients with CF, both pre-transplant and both. And this included at the University of Minnesota, where she became very close to several of her frequent flyer patients. She notes that her CF patients hold a very special place in her heart. We are honored to have you here with us, Leslie, so to increase our understanding of pulmonary rehabilitation. Please help me welcome Leslie.
Good evening, everyone. Thank you so much for that gracious introduction. I'm Leslie, and I have been a RT for way longer than I care to admit to, but you know, it's a good thing. And I finally have found a job that I love, only because when you're working in acute care, inpatient in the hospital, you see people in crises. And when I'm working now with outpatients and working with people in pulmonary rehabilitation, I have people with me for quite a prolonged period of time. Our program lasts 8 weeks, and I see people twice a week for about 2.5 hours at a shot. So Tuesdays and Thursdays, we see people for 5 hours altogether. And so we see a lot of progress in that amount of time. So today we're going to talk what I know best is benefits of pulmonary rehab. Hopefully we can hone in on some of the benefits that are more specific to cystic fibrosis. We, and actually most programs that I'm aware of, do have a multidisciplinary approach. And once you're enrolled with us, we become part of your healthcare team. We'll discover and explore a little bit the components of rehab, and then really what is most beneficial and what people tend to get the life change with is the benefits of lifelong exercise. If you don't commit to a lifestyle change, within about 3 months you backslide to just where you were before you came into rehab. So 2009 was kind of a milestone for pulmonary rehab. At that time, the American Thoracic Society, who's kind of well-respected, not kind of well-respected, but they're sort of the who's who of pulmonary disease. And they, at that time, noted that people with any chronic respiratory disease are going to be benefited from individualized treatment to reduce their symptoms, optimize functional status, and reduce healthcare costs through stabilizing or reversing systemic manifestations of the disease. And the more you adhere to your treatment program, the more you're going to find that this is really useful for you. Now, you're probably wondering a little bit why I have this slide on Medicare, except that once Medicare recognizes that rehabilitation is a valid intervention for making someone to feel better, to maintain quality of life, and that they will actually reimburse for it, all of a sudden, all the other insurances jump on board. Everyone looks to Medicare to see what is reimbursable. So 2010, finally, the comprehensive PR programs for patients moderate to severe COPD, they granted that this is a great intervention for anyone with chronic respiratory impairment. And a lot of this was due to our lobbyists with the California Society for Pulmonary Rehab. They're very dedicated individuals in our state society. So this is very brief review of cystic fibrosis. You probably know your symptoms and your manifestations more than I do. But bronchiectasis is huge for people with cystic fibrosis. The airflow limitation, the pulmonary infections, the hyperinflation, we address all those in rehab, and there is our team. So you may recognize me. That's our core team. I'm the one on the left in the gray, and then the gal in the blonde hair is Missy, and Karen is one of the nurses that I work with as well. So when we discuss who does what in amongst the team, you'll kind of have more of a idea of who's who on our team. So there's our core team. So as the respiratory therapist, I talk a lot about medication, supplemental oxygen, infection control, airway clearance, diagnostic testing, pulmonary assessment. Our RNs, Missy is an ex-critical care nurse, Karen is our stress management specialist. They bring a lot of clinical expertise to the floor. Remember, we're in an outpatient area, and if something happens that's emergent, we need intervention, and we're there basically by ourselves. So we all have to be ACLS certified, and we have to be able to make a quick assessment and make a quick intervention if anything were to happen during exercise. So it's really great to have strong team members. Our physical therapists teach a lot of balance training, falls prevention, safety in the home. We have a registered dietitian, I believe, and she makes a lot of nutritional recommendations. I'm sure probably most of you already have a nutritionist that you work with, but it's really nice to have someone who is a certified diabetic educator that you can make a one-on-one appointment with. And then I sit down every week with our medical director and every new patient that we're looking at to see if they're meeting the criteria to be admitted into the program, if they're appropriate for the program. He reviews all the tests with me and looks at all the individualized treatment plans that I've drawn up. So one of the big questions is, will exercise help and why will it help? Well, we've got a lot of data that supports anyone with a chronic pulmonary disease. Exercise helps a lot. We did our own small mini study about a year and a half ago on shoulder girdle strength and decreasing shortness of breath symptoms. And we found that it was a slightly flawed study in that we didn't progress people quickly enough to push them to work harder with their upper body. But people that have a stronger shoulder girdle actually decrease their shortness of breath symptoms when they're exercising, not only with the upper body strengthening, but also with aerobic exercise. And then this, I think, is kind of an interesting study by Patricia Nixon. So lower risk of dying if you have higher fitness, aerobic fitness level. So it was a fairly good-sized study. It wasn't huge, but 3 times as likely to survive than patients with lower level of fitness. And what we find in rehab is people that do end up hospitalized, if they're more fit, their hospitalization stay is usually shorter, usually 2 to 3 days. And with the cystic population, it may be longer than that. But we find that if people are fit and they're strong, they tend to recover a lot more quickly, and their immune system is a lot stronger. So here's our gym. It's kind of a typical gym. We're fortunate we moved. We now have windows. And back in the back is where we have our emergency equipment. We've got a lot of seated equipment. We do have treadmills, and back here where you can't see, we actually have standing ellipticals. We've got spin bikes right here. And the reason we have so much seated equipment is often our people come in and they're pretty debilitated, or they've got joint issues, or people that have been diabetic for a while. They have neuropathy. They have numbness in their feet. They're not really safe to do standing exercise, but we have found that if we keep you seated and really increase the resistance in your legs or in your arms, we can still build a lot of muscle endurance. And so you'd probably be quite surprised at the amount of energy that these people are consuming and producing in there. We measure METs. A MET is a level of energy you're producing. So just sitting here in the room, we're all burning 1 MET. You're consuming oxygen, your brain's working, your blood's flowing, your heart's beating. And so most of the time, even the first time in, our people are coming in and they're starting out at 2.5 METs just by increasing their movement. What that translates to is increased muscle strength. So typical day in our unit. Come on in. We would take your weight and vital signs every time you come in. If you're an oxygen user, we'd put you on oxygen. Once you get to the hospital, we want you to come, and we are located in the hospital. We're attached to the hospital, but we're in an outpatient department. So you can see the emergency department catty corner from the gym. It's quite convenient. Rarely do we need to go there, but it's a great location if we do. So people wear their oxygen in. We switch them over to our supply once they arrive in, and people turn in their exercise journals. We do ask patients to keep a journal of their exercise when they're not at the hospital. It makes people a little more accountable, especially we find that people come in and they're not exercisers. I hate exercising. I've never been an exerciser. If you can get people to just say commit to a 10-minute walk 2 times a week, that usually turns into a 20 or 25-minute walk. So writing it down makes people a little bit more adherent to exercising. So we do a group warm-up, standing balance unless someone is totally unsafe. We do stand by a chair. We do a lot of balance exercising, a lot of upper body strengthening. Once we finish our group, then we move out into the gym, and we've created an individualized treatment plan. And we always want to stress to people when they come in that some people are higher functioning than others. Right now, I've got an 85-year-old gentleman that is going like a house afire on the standing elliptical, arms and legs. He would drive me under the table, and yet he had to quit running at 80 because his knees blew out. It's not to say he doesn't have lung disease, but he had been an exerciser for a long time. And then we've got people in their 30s that are starting it, that haven't been able to exercise for 4 years. And so we start them on that seated equipment where we can start them pretty slow, maybe use a single muscle group where their legs move or their arms move in order to not over deplete their oxygen that they're able to supply to their own bodies. So once we finish the aerobic exercise portion, we come back to our little group cool down area, we stretch. We've got a captive audience, and when we do, it's a great time to start sharing little nuggets of information. we want you to eat more plant-based diet. Here's why. Here's what it does for your recovery. Often if you eat certain things, they don't burn as much oxygen to digest, or you don't have as high CO2 levels. So we'll just throw out a little nugget. We do breathing retraining, which I'll go into a little more in depth in a moment here. And then once we finish that part of the session, we move into an educational session. So there are two key components of the pulmonary rehab program. You really get the biggest benefit from the exercise, but what is helpful and builds more of a symbiosis with the class is these educational sessions when they sit in the sessions and really can share and get to know each other. Out in the gym, most people are too short of breath to talk. And some people are wearing masks, or some people are too focused on their exercise. But once they get into a room and we have group discussion, it's pretty heartwarming to see how the 85-year-olds are, they're becoming friends with the 27-year-olds. It's really something. So we hand out a lot of materials. You get a little textbook. It's quite simple. We keep our education materials at a very low level, just so cartoons kind of get the point across. We do strength and balance training handouts. Part of our team, actually, we have clinical exercise physiologists as well as a physical therapist on the team. And so they're really able to help us create some good exercise routines for our patients. We hand out oxygen. Some people have a requirement for higher levels of oxygen. I don't know if anyone out there knows what an oximizer cannula is, but it's a device that can deliver a pretty high flow of oxygen, or you can decrease the amount of oxygen that is supplied to the patient so they don't go through their portable system as quickly. So it's an oximizer because you can usually turn the flow down a little bit lower but still get good results with oxygenation. When you're coming in, we check a quality of life measurement. Some people come in and they're depressed, or they don't even know they're depressed, or they feel that they're not, their perception of their health is actually worse than their health is, than the reality. So we do a quality of life measurement before and after. Some people, we repeat it during the mid-session, and it's really how we can assess if someone's progressing in one of our domains, which is the psychosocial domain. We want to see improvement in every single area that we are addressing in rehab. We teach the Borg scale, which is a shortness of breath scale. It's a way for us to assess if someone's understanding their perceived exertion. We encourage people, in fact, the train of thought now, I was a little shocked, but we discussed this at our last regional California Society for Pulmonary Rehab meeting, is that we are pushing patients now to work to a perceived exertion of about 4 to 6, which is somewhat severe to severe. And we're seeing better, faster results with achieving fitness and muscle endurance. But that means our patients have to really trust that they're going to be safe working at that high of a level. Now, I'm not saying that you come in and you're exercising for your whole hour and a half at a shortness of breath of 5 or 6. But what I'm saying is we often encourage interval training, which means you're working, it's like high intensity training that some of you may do at the gym, where you kick it out, you're kicking it out for 30 seconds, a minute, 15 seconds, whatever you tolerate, and then you pull it back, not to the point where you actually stop exercising. You want your heart rate to keep going, you want your shortness of breath up there, but you can recover. And it tends to make people feel a little more empowered. Oh my gosh, I can push it, but I can recover. And the next few sessions, you actually start to see improvements quite a bit more quickly. So we do use, these are two also dear to my hearts, the inspiratory muscle trainer. We use the threshold, and I'll talk about that in a little bit. And we use harmonica therapy. So studies have shown that both The inspiratory muscle trainer can sort of be swapped out, if you will. If you enjoy playing music, some of our patients love playing the harmonica. We have an actual blues harmonica player come in, instruct the patients. There have been some studies, or not huge amounts of studies out there, but patients that are doing harmonica are getting a lot better diaphragmatic movement and strength. And people have gas doing it. We've got a harmonica group that meets, and they start out in the beginners group. And once they get into the more advanced group, they actually go do gigs out with their instructor out in pubs. So these people are starting to rock it out. They're having a lot of fun. We hand out a meditation CD. We have a lot of issues with anxiety with people coming into rehab, and so we do encourage mindfulness and meditation. We have airway clearance devices, and we cover it. For the cystic population, probably you could teach me way more than I can teach you about airway clearance, but we do have devices available. We use the aerobica, we use the flutter valve, the acapella. We have a lung flute, which I am not very successful at using, but we do chest physio, so we don't usually demonstrate a vest, but you're getting the idea. And then we do sell the spacers for medications, because often people take their inhaled medications without a spacer, and we all know that you only get about a tenth of what is supposed to be delivered to you if you're taking a meter dose inhaler without a spacer. So inspiratory muscle training, this is our threshold device. There has been, and unfortunately, I did not cite the person who did this study, but it was out of Edinburgh, and a significant increase in inspiratory strength found in the CF population if they were adherent to using their inspiratory muscle trainer. So they had increased diaphragmatic thickness and inspiratory force. So there's a little thing called a manometer that you have them breathe against. And you can measure how much stronger, how much more flexible the diaphragm gets when they're using this inspiratory muscle trainer. They've measured improved lung volumes and chest geometry. So really all chest geometry is, your rib cage expands from bottom to top. And when you're inhaling, if you can get that full three-dimensional expansion, and you can get all the intercostal muscles in between your ribs involved, you're going to be able to move volumes better, right? You do need to overload the muscle in order to produce an effective strengthening. So just like I was saying, we really push people to work hard in the gym. We do push people to, quote, overload their muscle. If you're exercising a little bit, we want a little quivery in your muscles. We don't want you to be being able to flip your weights around. Same thing with a ventilatory muscle trainer. We want there to be effort there. That's how you build muscle. We don't want you to overuse it. We don't want you to get so sore you can't take a breath. But if you do combine the aerobic training with the inspiratory muscle training, you really find that you get increased exercise capacity. And the more exercise capacity you have, the easier it is to stay healthy. So here's one of our patients. She's firmly embraced playing the harmonica. You can see she's got her practice partner. And she was the cutest Scottish lady, and she actually came through the program twice. And she loved playing the harmonica, and her dog loved to play harmonica with her. So we had to include a picture of this, but she was in our group. So, here's some of the benefits more specific to people with secretions. If you've got a lot of pulmonary manifestations with your CF, it can help you clear secretions, right? You start breathing deeper, your lungs start expanding more, you're breathing heavier. I mean, it stands to reason those secretions are just going to start to mobilize a little bit without a lot of chest physio. It helps you to improve your physical condition. Your immune system is boosted. There's a big correlation between blood sugar control and exercise. We check blood sugars every time we have someone that's diabetic, before and after exercise. And we often find, depending on people's diet habits, which are quite influential, as you can imagine, in your blood glucose, but we often find people's blood sugar will drop 100 to 125 points after they've done a pretty intensive exercise. So we really want to monitor that blood sugar. One of the things we do want to caution our CF patients about, because of the sodium issues, is if you are going to be, and this should be looped in when you're getting referred in, if you're going to be exercising pretty heavily, you're going to sweat, you may need dietary or supplemental adjustments. So either your physician or probably your dietitian, your nutritionist can help guide you with that. But believe me, as people get more advanced in the program, they come in, they're often tentative, they don't want to exercise 5 or 10 minutes, and then at the end of the program, we can't drag them off the aerobic equipment, we're flashing the lights, this is your signal, and people are they feel good when they sweat. You know, it's important to sweat and use your muscles. So everything we do in pulmonary rehab leads back to measuring an outcome. So our assessment, we look at both physical improvements and also psychosocial improvements. For a physical assessment, we look at a 6-minute walk test. We look at heart rate response, blood pressure response, blood sugar response. So we make an assessment before they start the class, after, and in midpoint through. We do education. We actually have a little, quote, final exam. It gives our patients a little bit of anxiety. We send it home, it's open book, and then we sit with everybody in a group and we go over the test. It does become part of your permanent chart. Exercise, from the first day you're there, we start to note if you're using a weight for upper body strengthening, if you're just using your arm. You know, if you lift your arm's pretty heavy in itself. We've got everything in our gym, from very small weights, 1-pound weights, all the way up to about 30-pound weights. And as you would speculate, most of our pulmonary patients, we've got a couple of guys now that are using the 8-pound weights, but you know, they're usually in the 1 to 5-pound range. So most of our people don't have a huge amount of upper body strength, but we measure METs, as we were discussing earlier, the energy expenditure each time you come in. And then we compare that 1 week, 3 weeks, and then when you're getting ready to graduate. And sometimes people will quadruple the amount of METs that they are burning during an exercise session from first to 16th session. Psychosocial is really that whole thing about what's your quality of life. Are you depressed? I'm not sure with the CF population how much depression is prevalent, but in our COPD population, often it goes undetected for years and years and years, and then all of a sudden someone has an exacerbation, all of a sudden they realize they've got a chronic condition. You know, with most of the CF people, you grow up with it, right? You're managing it your whole life. So there may not be the psychosocial issues, or they may be of a totally different avenue than we're seeing with our other chronic lung illnesses. And the big thing here is we really want to stress long-term adherence. From day one, we start trying to get people, we work on coordinating and developing a strategy. How do I get this person to embrace exercise? How do I find something that they're going to enjoy and they're going to get pleasure from and benefit from? And how do I keep them motivated to continue this once they've graduated out of our program? There had been, for the longest time, and that's one of the reasons, going back to that Medicare slide, physicians weren't wanting to refer to pulmonary rehab because it's feel good, it feels good. Well, what's wrong with having an improved quality of life? Or what's wrong with being able to unload your own groceries out of the car or put away your own canned goods? So we're seeing evidence now that going through a rehab program increases lifespan, it decreases hospitalizations or hospitalization stays, and it decreases readmissions. And we finally are doing the research to see that. So the long-term adherence is huge. So each of these components we actually do assess as they go through the program. So one of the goals, or all the goals, I guess, are listed here. The exercise training, we really want you to see it as training for life. We have one of your graduates, actually, or one of your, not graduates, one of our graduates, but she is a member of the Research Institute, I believe, or at least is involved with it. And she ran a half marathon after she went through the program. So that, before she was transplanted, I'm not going to mention her by name, but she came in and said in order to prep for her transplant, she trained like she was training for a marathon. And then she came into rehab, and she was one of our stellar students, and she was there every single session. She was exercising outside of class, and by God, if she didn't run half a marathon, and she wrote to tell us about it about a year later, it brought tears to all of our eyes. I mean, we were like, wow, we helped to contribute to that. So it's, we really want you to get that whole thing, that it's important and it's something to keep going forward with. Activities of daily living. Who doesn't want to be able to change their bed and put their sheets on and then go throw it into the laundry? A lot of people don't have the energy to do that all at one sitting. We had somebody come in that it took her 4 days to clean out her refrigerator. Now, after she graduated, she was able to do it toward the end of the program. She goes, I could clean it out in 1 day. Now, to me, it doesn't sound like a very exciting activity. But if you're somebody that takes pleasure in maintaining your household, that's a pretty huge accomplishment. We want to improve your strength, teach you energy conserving techniques. How can you get in and out of the shower? Use a terry cloth bathrobe instead of, if you're having a bad breathing day, put on terry cloth slippers, terry cloth bathrobe, blow yourself off with a hair dryer. Things that you can do to not burn your energy so you have energy to go out and do things you love. Group support. Some people think it's a little touchy-feely. I sort of did when I started doing the rehab. And then now I see how much people come to appreciate each other in these groups. And not often do people leave the groups with new best friends. But the concern and the care that is there, that develops, and the relationships that develop from week to week to week to day, it's pretty rewarding to be a part of. And then we really want you to know, wherever you are in the program, we want to keep developing an individualized treatment plan for you. I mean, we think that you're somebody that would benefit from going to a gym or coming to our pulmonary maintenance program, we will start to stress that as we go forward with the program. So patient criteria, we'll kind of blow through this. We see anyone with any kind of chronic respiratory illness. You're going to be in a class with someone with cystic fibrosis, pulmonary fibrosis, COPD, transplant, lung volume reduction surgery, bronchiectasis, sarcoidosis. We see some very unusual pulmonary diagnoses that I've only seen once in my entire career. So there are certain ICD-9 codes. Does everybody know what an ICD-9 code is? There are certain things that will be reimbursed, and we're seeing more and more of those, and we're taking advantage of being able to get those people help. You've got to have these symptoms. You're fatigued, you've got a lot of chronic respiratory symptoms, you're short of breath trying to live your life. So if your activities of daily life are affected, your quality of life is affected. So we want to address that. If your functional status is not quite what you want, I can't go grocery shopping. I have to drive a cart instead of push a cart. I can't golf at all anymore, even in a cart. we address that. We try to find solutions for people, try to improve their quality of life and their functional status to make that a little bit better for them. And then you can come in a couple of ways. You can come into the program either calling us. I just got someone into the program who had seen us online. I think she saw us online. We've had friends of friends recommend it, or the physician may be the impetus for referring a patient into our program, or any program. Doesn't have to be my program, but it's definitely a first step, and we will assess and make sure you're appropriate for that. So you'll come in, we'll do a quick little physical assessment, nothing different than you would have at the clinic. Look at your breathing pattern, listen to your lungs, check and see if you have finger clubbing or using your accessory muscles, assess your oximetry. And then we will do a 6-minute walk test, and that's really when we can kind of see how you move and if you're having any issues with any of the extremities, upper and lower body. On the 6-minute walk test, I'm sure some of you out there do one on a regular basis. We have a track out in our hallway. It's flat. It's 100 feet from end to end. I'm there to observe your gait steadiness. Are you listing off to one side? Do you have a funny little gait disturbance? Maybe you're knock-kneed, maybe you're not pigeon-toed, but maybe you're duck-footed. These are things we can actually help to assess and make corrections with out in the gym, or address, especially if it's creating pain or discomfort in a hip or knee. We check to see if you need oxygen with exercise. It really helps us to look at where to start you out with your individual treatment plan. Do we start you out at a pretty low level, low intensity exercise? Or do we put you right up on the treadmill, might be at 1 mile an hour or 1.5 mile an hour, but are you stable enough to be up there? Should you be weight bearing? So that's when we assess your functional limitations and how well you're moving, how well you're weight bearing. And the other thing we do is see what happens to your breathing when you're out in the hall. We have a lot of people come in that have not been prescribed a rapid onset inhaler. And it's like, well, why not? You wheeze when you walk. But the physician doesn't see that, and it's not reported to the physician, but we see it as we're doing our assessment. So this is actually a sample of questions that's on a survey that we send to the home. So how short of breath do you get dressing or talking? Some people get extremely short of breath. Hygiene activities, do those bother you? Changing linens, house chores, groceries, putting things up in a cabinet, bending over. Did you give up going to your son's football games? Can you get up and down the bleachers? What about bringing your children to school? Did you used to walk them to school and now you need to drop them off in the car? So we can kind of see when things started to go downhill. And then how about bending over to pick up your children? Can you do that? Can you hold them on your lap? Does it limit your breathing? So we ask a lot of questions, and not just because we're becoming nosy, but we're trying to get to know you. So, you've got nutritional needs you need addressed. Probably many of you already work with a nutritionist or have had an encounter with a nutritionist. But a lot of needs that are non-pulmonary related, and we've got a dietitian who can help with the pancreatic insufficiency and challenges for your nutritional health, constipation. We do have that diabetic educator on our team. We do check your blood sugar. We talked about that a little bit. We look for a BMI, body mass index. So what that is with your height and your weight, are you within the table's norms? So if you're pretty low on your body mass index, we may exercise you a little bit differently than if you were smack in the middle. If you were 23, 24, we might be able to push you harder or expect more from you if your BMI was in that range. If you're down in the range where you're almost looking like you're near starvation, we're probably going to look more for a little bit less intense, but still try to build some muscle endurance and strength. So we change our exercise prescription looking at the BMI. And then do you have an issue with fluid retention? You know, that's huge because we check weight every time you come in. We don't want someone going into a little congestive heart failure before we put them on aerobic equipment. So we ask about sensory issues. Anybody hard of hearing? You blind? Do you have any have you had a small stroke? Are you able to process information that comes to you? There might be a language barrier. English may be a second language for you. So why don't we have a translator. We usually can pull up on, we have little iPads, so we have a translating person that we can call up doing FaceTime with. Is everybody familiar with their iPad? Sometimes there are cultural issues. You know, men don't exercise in the same room as women. We have to suss that out before we try to bring somebody into the room and all of a sudden you got 16 people in the gym and somebody won't exercise next to somebody else. Anxiety is huge. We just overcame a huge barrier with someone that was too anxious to wear oxygen. She had a bad experience with a cylinder early in her life where, if anyone's familiar with the little oxygen cylinders, they've got a valve on the top, and if they break off, there's a lot of pressure held in that cylinder, and it took off around the room and lodged into the wall, and so she was afraid of the oxygen. So we finally calmed her fears. We got her to see how much better she felt using it, but we often deal with anxiety. Some people come in with substance abuse. I remember sitting with an orientation one time and somebody told me, oh, yeah, I smoke crack. And what do you say to that? You know, you're looking nonplussed and you're trying not to be judgmental, and it's like, well, that's not good for your lungs. You know, you do encounter these things, so you need to be able to manage those things. And then, are you ready? Are you really wanting to come in, or are you coming in because my doctor recommended it? So, you know, it's like that Nike commercial. Are you ready to do it or not? First day, we bring you in, we introduce you to the team, and you're going to look around the room, probably use cystics in particular, and say, wow, everybody's really old in here. Because many of our patients are older. Probably the average age is in the 70s, and that's not a bad thing. They bring a lot of sage wisdom to us. I would never know most of these people and for any other reason in my life. I currently have a World War II vet that exercises next to a Hiroshima survivor. I would never encounter these people anywhere else in my life. So, okay, you know, they might be a little older than you, but don't you want to get there? And this is how you're going to do it. This is how you're going to help your survivability. I don't know if I can really exercise. Well, you can, and we're going to show you how. You know, make sure you talk to us when you come into the program. Any questions, any skeptical input you might have, please address it with us. And, you know, if you're pretty deconditioned, if you haven't exercised for 4 years due to exacerbation after exacerbation, you didn't get there overnight. You didn't decondition overnight. So it's going to take you a while to recondition. Be kind to yourself. Don't beat yourself up. You know, how come that 85-year-old man over there is going like that and I can only go 20 minutes? Well, he wasn't doing that when he started here, okay? And he was active before he came in, so let's be nice to ourselves. So not all educational topics are going to be relevant to people with CF. You managed your disease process. I like to call things now a chronic condition. I don't really care to call things a disease. But you know a lot about infection control already. We have a class list of all the topics of our lectures, and we encourage you to participate in all the lectures, but some things are probably going to be a little more entertaining or a little more pertinent to you. Not entertaining necessarily, or they may be, but the ones that the CF people find are the stress management, energy conservation, the mid-session. They like sitting down with the other people and sitting down with their medical director. The emotional, social, it's also advanced healthcare planning, palliative care, things that happen as you progress along in your life. Travel planning and sleep disorders. Ex-phys tends to be one that we see a lot of people come to with CF. So, kind of pick and choose, but I'm pretty sure you'd be able to take away a nugget or two from each and every topic. So you're going to find once you're getting near the end here that you have better exercise performance, you can do your day-to-day activities better, your quality of life is improved. Most people say that they just find that their outlook is better. Just exercise will improve your daily outlook. You do have better blood glucose control, fewer psychosocial symptoms, and then you get to have a lot of face time with us. When you're out on the gym floor, we're there one-on-one with you. If we have a really big class, we may not be able to spend more than 5 minutes or so with you, but it's a good time. You've got us as a captive audience then, and we can answer any questions you may have. Or if you have a private thing you want to talk about, we can go into a room and talk about that. So we're getting close to wrapping it up here. This is just how important to me that patient education is.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and you need to try twice as hard to fix them. You using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So when I was going through my asthma education training, one of the things they stressed was every time you see your healthcare provider or every time you see a patient, ask them to show you how they're using their medications, because something in the brain will get derailed during an application, during administration, and chances are, even if you saw somebody 2 weeks previous, something's changed. So always, always, always have them show you how to use the medications. So what we really want you to take away from rehab, we want you to understand and be able to validate your knowledge and skills. So we do a lot of return demonstration that we document on. So we'll have you, if we're teaching CPT, we have you do CPT with us. We have you huff cough. We have you do controlled coughing. We have you get down on the floor and get up. It sounds like it's not a big deal, but some people don't have strength in their legs, or they've got a bad hip, or they can't feel their feet. So we actually do return demonstration. That's how we validate your knowledge and skills. We have a heck of a lot of fun. This is the first time in my life I've loved my job, and we laugh a lot, and we get pretty tight with our patients. It's a really safe environment. You can work out very safely in this environment. We can push you. You can learn how to push yourself safely. You learn how to pace yourself. If you're committed to change, if you come in ready to begin exercising, if you're ready to begin being an active person, you're going to see a big change. We only have you for 2 months. It takes about 60 days to start to create a habit. And so we've had comments, people would like us to extend the program to 12 weeks, and it's hard enough to get people to come for 2 months, let alone 12 weeks. But, we're thinking about it. But if you're committed to change, we're committed to being there to help you through it. And then just really progress slowly. Don't worry about what the guy on the elliptical next to you is doing. And here's how to get a hold of me if you have any questions. And I'm ready for questions if there are any out there.
Thank you for the presentation. Can you hear me? Yeah. I actually have a ton of questions. So the first question I have, and of course every question I have is related to CF, obviously. So how bad a person has to have CF, or how down they have to be on the FEV1, for example, to be referred to you or for you to accept in the program?
Well, you need to have the pulmonary manifestations, your quality of life, your activities of daily living need to be impacted. But if FEV1 for COPD, we have to have someone about 65% or less. But if we can document that someone's short of breath with exertion, they require assistance for activities of daily living, if we can document that someone would benefit from a strengthening and exercise program and education, then we can get it covered. And we run an insurance check before we actually bring somebody in. So their contact is made. I talk to them on the phone. I collect insurance information. And then if it's come from the physician, they've probably already sent me an order and referral form, and may have even already sent me a PFT. So once I have all that documentation, I can look at it and kind of determine whether or not the numbers qualify, or if I've got a history and physical, if someone's been in the hospital and all of a sudden they've lost ground, if their condition has declined to the point where their life is impacted, we can usually argue and document enough where we can get someone in.
Do you know if you work with Kaiser, or that's...
We get referrals from Kaiser Santa Clara, but I haven't had any from any other Kaiser. I know Kaiser up in Sacramento has their own pulmonary rehab program, but if you get a referral from Kaiser, either primary care or pulmonology, we do have a contract in place.
Okay, I'll ask. You mentioned intra, and I forgot what was the muscle training. So what is it exactly?
It looks a little bit, well, the old one we had looked like a kazoo. The one that we have now has a mouthpiece, it's clear, and it's spring-loaded. So there's a little tail on it that you kind of twist up, and on the side, I should have had a slide with it, it's measured in centimeters of water pressure. And so you can increase or decrease the resistance. So you put the mouthpiece in your mouth and breathe against it. And when you're working that hard to breathe, you pretty much need to utilize your diaphragm. So on the first day, on an introductory day, we don't even introduce the ventilatory muscle trainer, inspiratory muscle trainer on the first day. We teach pursed lip breathing, and we teach diaphragmatic breathing, because your diaphragm is your main muscle of breathing, right? And so we want you to be able to access it and get it to move freely before we try to train it to get it stronger.
Two more questions, and I pass it if you don't mind. So the other question I have is, if you have more than one CF person in the class, what do you do about infection control?
Well, I hope I can say this and I'm not violating HIPAA, but right now we have two, and they just sat at opposite ends of the room, and they both wear their respirator masks.
Now I'm completely sidetracked. I cannot remember my last question. The last question is, so does every transplant person get referred to some kind of rehabilitation therapy like yours?
It's part of the protocol, actually. We see transplants pre and post. You don't necessarily have to be bad enough within the process of your lung disease to be on the transplant list. In fact, if you come in before, you may be able to avoid transplant for a little while. But it is part of the protocol to see people before and after. Now, we often see people after but not before, because someone either went on emergently onto the transplant list, or they just didn't bother to come, or they didn't live in an area, which is another issue, where there was a pulmonary rehab program.
We have several viewers online, so we actually have a long list of questions, and I'll just go down the list. Someone also asked about cross-infection control. She asked, do you or they also wipe down the machines after use by everybody?
We have housekeeping come in every day. For our transplants, we wipe them down ourselves before they get on the machine. So we actually have one in rehab right now, a fairly recent transplant, and we wiped it down in front of her. We want people to know that they're safe. We use either Virex or the antibacterial wipes, that the hospital grade ones, and any surface that a patient is going to touch, we wipe down. And most of our people now are carrying their own oximeters. We have oximeters, but a lot of them carry their own oximeters. In fact, some people bring their own weights in, so we don't have to wipe down their weights every time they come in.
How intensive is the intake process? Does the program have written orders and health status from a patient's doctor? Can you recommend additional sessions once the doctor's initial prescription for the sessions have been completed?
So an initial session would be 16 sessions. And say if someone were on the transplant list waiting, and we can document, and that's why we do the treatment plan, and we do a session report every time you're in. And what we document is patient would benefit from a medically supervised exercise program while waiting for transplant.
Does health insurance cover costs?
For the most part. Now, if you're younger and employed, or if you're not Medicare, often there's a copay, unfortunately. Sometimes it's reasonable. Sometimes it's a $5 copay. Sometimes we have seen copays as high as $50 per session. So insurance normally does cover it. To the 100%, I can't speak to that. That's why we run the insurance check before we bring you into the program. So we would get your insurance information. I send it off to our finance people, and then they send it back with what they've discovered, but they also try to call whoever it is that I've submitted the insurance on the phone, so they can discuss it directly with them.
Why do you check BMI? I heard so many people talk about how a simple ratio of height to weight tells so little about a person's fitness.
Well, you know, there's some studies out that once you get overly active and you start burning your own muscle, trying to condition aerobically is sort of not an appropriate thing to do. So what we do is try to increase strength and endurance without necessarily having you burn a lot of calories. Okay, that answers that.
All right. You referred to some psychosocial issues earlier in the program. Who helps the group through an acceptance and grieving process if one of the group members with CF passes away after their time with the group?
We have actually 2 stress management specialist nurses on program. Karen, who you saw in the photo, the brunette, she had been a licensed counselor before she went to nursing school. And so she has stepped into that role, and people can meet with her one-on-one, or we can do it as a group. She does teach stress management as a group, or if you want, like I said, to make an appointment with her. So she's quite adept at it. She's actually helped me through some personal crises.
Another question regarding cross-infection. Do you wipe the machines between use for all CFers and not just post-transplants?
Well, to be honest, we haven't had that many patients with CF through the program right now, but if that is a protocol and a standard, we would do it.
Okay.
We wipe down before and after, and once a day, but not necessarily between each patient. But like I said, if that was protocol, we would adhere to that.
Do they accept GHPP insurance in addition to primary insurance?
I just found out what that was, and yes, they cover it. So I was pleased.
Autotoxicity, you might need to define that to some people in the audience. What are most effective exercises for those with balance issues?
Well, again, this is a very recent admission that we had to the program, and we've been doing balancing with her, and that's probably, we just do standard balance. We do have balance bars that we use, but normally we make sure someone's safe, standing by a chair. We have a stair that we do stairway that we do stairs training on, that there's a handle depending on someone's height. And then we have, if anybody's ever taken belly, we have a regular belly bar in there. But if someone is having a specific issue that needs to be addressed either by the physiologist or by the physical therapist, we would probably ask them for help and recommendations.
Okay. 3 more questions. I have never heard of the lung flute. What is it?
Oh, well, it's quite an interesting instrument. It was developed by a musician who happened to be an engineer. And it's, I think about this long, and it's sort of rectangular in shape, but it's wide at one end and narrower at the other, and there's a long reed in it. And you have to be able to, if anyone's ever used the flutter valve, there's quite a degree of skill and technique involved with the flutter versus a cappella or aerobica. And so with this particular lung flute, you have to hold it and try to sustain an exhalation to get the reed to vibrate, and then it uses that oscillation to mobilize the secretions. I can't do it. I demo it, but I can't do it very well.
That's a lot.
Yeah.
Does your hospital have a CF center? Do most CF centers have a pulmonary rehab program?
My hospital is a community hospital. In fact, we are contracted out with Lucille Packard, and they have an entire floor over in the main hospital. So there is a possibility that someone could actually be admitted to our hospital and come over to our rehab program. I'm in the old main hospital, there's the new hospital.
And the last question, how do I help my daughter get over her fear of aerobic exercise? She coughs so much when she exercises, she's now afraid.
She's afraid to exercise because of coughing? Well, I would start, I think, trying to set small contracts and very, very low intensity exercise. So we're going to exercise for a minute, and then we're going to rest for a minute. We're going to exercise for a minute, and then we're going to rest. So, hopefully we would do airway clearance and all that prior to coming in, see if we couldn't get a cough suppressant on board. Some of it is just knowing that you're going to be safe and not pass out from, that coughing is so intense with that population that it's a little frightening. But that would be my approach, and someone may have another approach. But I would just start with slow bouts of exercise and allow them to rest in between.
Thank you, Leslie.
You're welcome.
One more. It's not a question, but Just for your information, there's a product out on the market called Vibralung, and it's actually,
Saw that.
yeah, my daughter is using it in addition to the vest, and it also works on the same principle, sound waves, but it's electric. So you can, set the tension and then all these other gadgets, you can set on it. And it's really interesting when she does it, it gives different sounds. It's boop, 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 and that's what that's what it does. It's actually vibrates the lungs, so it's having the external pressure from the vest plus the internal vibration,
It's mucus shearing,
Yes,
right,
yeah,
up the airway,
yeah,
right?
yeah,
We just
yeah.
had someone come into our regional meeting to talk to us about it. And I demoed it, she's demoed it with me, and it was quite interesting. But I can see why it would be effective. It made me cough, and hopefully I don't have any lung disease, but I don't know. I hung out in discos enough.
So you have your CFers wearing N95 masks while they are exercising, or is it a different kind of isolation mask?
It's that, the mask that I've seen, it's like a neoprene.
Oh, so they're the very simple, the yellow kind of ward masks,
Well,
or?
these are kind of flashy. I mean, this one had a little medallion on it, and it's neoprene with a print. I mean, it was kind of snazzy. It looked a little bit like it was coordinated with her outfit. So.
And they don't find that they have difficulty getting enough air in
Not
to?
thus far. Now, I've had people, when I've been doing the 6-minute walk test that I brought in, who, because, often people post-op have brand-new lungs, and so they're breathing way better than they were pre-op. And I've had them take it off out in the hall because they felt like they were having a hard time breathing. But in class, most of the time, they wear their neoprene masks, and then we do have different kinds of masks available to them if that feels like it's too claustrophobic or too hot, more of the paper, surgical kind of masks. It's really up to the patient and what they're feeling comfortable with, the post-op people. But we really encourage them to keep, if they know their infection control protocols, please follow them.
Right.
Yeah.
Someone commented online that it's an N95 mask. N95 mask.
The neoprene ones?
According to one of our online.
Okay. Well, there you have it.
The masks are Resprotect mask. Post-transplants use them.
Exactly, yeah. Yeah, I mean, the N95s that I was accustomed to, it looked like a little pig nose, and it was, and there was those white ones, and, you get stuck and they give you a headache because you're breathing CO2 all the time, and, I'm hoping that the new neoprene ones are a little less claustrophobic.
Thank you very much, Leslie. That was an incredible presentation, and truly the huge list of questions, both from people in the room and our viewers online, really speaks to how much you had to share and how interested people are in this topic. So thank you. Tremendously helpful to our community.
My pleasure.
And for all of you here that are in the room, I just want to remind you that the evaluations that are on your chairs are really helpful for us, both for program outcomes to know whether we're making a difference having these presentations, but also really helps us with future program planning. And for those of you online who are watching us in the past, we just lost your information. But tomorrow we are sending out our weekly e-blast that we send out from CFRI, and we are actually going to include a link to a Survey Monkey for all of you who are watching and sending in your questions. And we really hope that you will participate online so we can get that information. Once again, I want to give a special thanks to Genentech and Vertex for sponsoring tonight's Discovery Series, and also to Activists for its additional support. And thank you for the representatives who have come here tonight. And all of us here at CFRI look forward to seeing you at our next CF Discovery Series, which we will explore CF pathogens, and that will be held on Tuesday, October 13th. So thank you and good night.